morning. We have lots of folks coming in, so it's so good to have you in here. If you are able to hear my voice and see my screen, if you can please type yes into the chat. All right, lots of folks coming in. Great to have you in here today. Thank you so much for joining us on a Wednesday on your lunch hour. Thank you, thank you, thank you. All right, excellent, excellent. Well, we have about 900 people, over 900 people registered for this webinar. So we expect a lot of people in, and we absolutely love the attendance. We have several hundred in right now. So that is fantastic. I'm going to stop sharing my screen for just a second and throw it right back up. So give me just one moment to do that. Also give us some time for folks to come in. But while we're waiting on some other individuals to join us, because you guys are the early arrivers, love that. Love that. But do you mind sharing, because in webinars, I like to tailor the webinar to the disciplines that are in the webinar, and also love to find out where you're at. So if you don't mind sharing, and you can do that, and we have the private chat. So if you don't want it in public, not a problem, just put it right in private. But also you can put it right in the public chat where you're from and what your discipline is, if you don't mind sharing that. That would be great. Lets everybody get to know each other as well. So really nice. Chantel, Pittsburgh. I grew up in Pittsburgh. That's a wonderful place. Arizona, uh, Colorado Springs. Great. New Jersey, Florida, Baltimore. Love Baltimore. Excellent. Georgia, Denver, Colorado. We got quite a few folks from Denver area. That is absolutely wonderful. Chattanooga, Tennessee, Texas, PA. That's great. Ohio, Houston, California, Louisiana. Excellent. Excellent. Great. Pakistan. Fantastic. Fantastic. All right. That is absolutely wonderful. This is fantastic. We have a great group of individuals in today as well, and all types of disciplines. I'm seeing LCSWs, LPCs, seeing nurse practitioners, psychiatrists. So really fantastic. That is absolutely wonderful. So thank you. This is great. All right. I'm going to start sharing my window now. Hopefully you can see this where you're going to. All right. Great. Ottawa. Excellent. UK, London, Philippines. I absolutely love this. This is fantastic. We have such a great array of people in today from all over. So all kinds of disciplines. Absolutely loving this. This is fantastic. So, well, welcome to our webinar on compassionate conversations, navigating suicidal ideation with clients. I'm absolutely delighted to have you here today because this is a critical discussion and a compassionate discussion. And professionals in mental health, such as yourself, all play a key role in supporting and also guiding individuals who are struggling with suicidal ideation. So during this webinar, we're going to explore some of those really sensitive topics and essential topics on addressing suicidal ideation with empathy, with understanding, and with professionalism. And I am sure that you guys are already doing this because you have such great backgrounds, but we're just going to go over also some key tools. And so my aim here is just to equip you with these tools and strategies needed to engage in these compassionate conversations that could really make a significant difference in the lives of your patients. So, because mental health, a lot of people feel like it's just about, that are not in mental health, feel like it's just about diagnosing and treating symptoms, but that's not at all what it is. It's about fostering connections and providing people with empathy and hope. So, I love active participation, and I hope that you will feel comfortable just asking questions. I love when people share experiences and engage throughout this whole dialogue and this webinar. So again, right now we have several hundred people in the room, from wonderful, wonderful areas and all over the world. It's so fascinating. And so there's a large wealth of knowledge right here in this room right now that you're a part of. So sharing and talking together is really going to enhance our abilities as mental health professionals and contribute to a safer and more supportive world, right? If whole world for those that are in crisis. So now we have the QA, so you can answer or ask questions in the QA. We have the private chats, and we also have public chats. Now, the private chats, only myself and the moderators see the discussion, and in the public chats, everybody can see the discussion. So, and if I pause what I'm doing, that's probably me looking at the chat, and I might not respond right away, but I will absolutely respond. So, all right, fantastic, fantastic. So, what we're going to dive right into is why this is so important. So I'd like to talk about that first, kind of why this is such a pivotal conversation that we're having right now. And so I love to include statistics. This is just in 2020, over the past year, thoughts and kind of behaviors among adults in the US. So suicide is undeniably a significant and concerning issue in the United States. And it impacts individuals and families all across the nation. And unfortunately, especially in the United States, as in other places in the world, we've seen a steady rise in suicide rate over the past several decades. My background is, and my name is on the screen, and I don't like to talk very much about myself, but my name is October Boyles. I am a DMP, and I have been working in mental health now for well over 20 years. So, well over 20 years. And so I love mental health. I love all aspects of mental health. And I work as the chief clinical and customer officer at Notes, which gives me a really unique advantage of being able to talk to individuals throughout the US and in other countries, whether it's a part-time solo practitioner all the way to large individual hospitals. And so it's an exciting time. I get to really see how mental health is changing, also see it from the electronic health perspective. And very quickly, my background was I worked for, I have been frontline staff for many, many years, but I also worked for a law firm that protected mental health professionals. Okay. So not that went after mental health professionals, but actually protected mental health professionals. And so I'm going to we're going to be talking about some legal things in here and how you can protect yourself as well. Okay. Now, just getting back. So thank you for asking. I do appreciate the person that did that in private. Thank you. But suicide really affects people of all ages, genders, backgrounds. It does not discriminate, right? No discrimination in suicide. But certain demographic groups are disproportionately affected, and that's middle-aged men, the veteran population, LG, LGBTQ plus individuals, and Native American communities have notable higher suicide rates. Okay. And there's also a lot of underreporting going on, happening as well. And I'd like to get your views on that. Do you feel like suicides are underreported, and a lot of times maybe classified as accidents or deaths? And that makes, I feel like, it difficult to capture some of the full scope of the problem accurately with that. And I'll give you a quick story, just a quick story. I am an avid scuba diver. I love diving. I've been diving for about 15 years now. And several years ago, I went on a dive, and there was the dive master was fantastic, very well trained, kind of a veteran in his field. And there had been a death at the particular site a few months before when I was going to dive. So I, out of curiosity, just went to the dive master and said, "Hey, I just want to know what happened at with that person that passed away. Is there something that I need to do differently with my gear? Do I need to descend a little slower?" We were just talking about that, and the dive instructor was really, or the dive master was just really got a solemn look on his face, and he said, that particular day, I shouldn't have let that person die, because when they got on the boat, everybody, when they get on the boat to go out to a dive, is really, really happy, right? They're very, very happy. And um, Unfortunately, this person was not happy, very solemn, and went and dove, left their dive buddy, and went down to a depth that is too far. And what happens when you get down in those depths is you actually get a little drunk. I mean, that's the easiest way to describe it. It's a process that happens in the brain because of the depth that you're at, and they kept going. And so, and they did pass away. So that is something that was reported as an accidental dive death, which was in fact they felt strongly was a suicide. So underreporting, and I was just wondering what your guys' thoughts were that on that as far as underreporting. Do you feel that that's an issue with suicide, or do you not feel it's an issue? Love to get comments on that and kind of see what your thoughts are on that. So other things that also kind of plagues suicide is this: there's still a stigma and misunderstanding, and we're really working hard on trying that to fix that, and I think we have come a long way in the past several years, but we still have a long way to go. So, and Deborah's saying yes, absolutely. Thank you, Deborah. Thank you, thank you. So next we're going to talk about the numbers. I think seeing numbers really it's impactful. So if you see, suicide was the 12th leading overall cause of death in the United States. It claimed the life of over 45,000 people, and but it is the second leading cause of death in individuals 10 to 14 and 25 to 34. So, and then as we see, it's the third in 15 to 24. So, and then you never want to see suicide in this category. You don't want to see it in any category across the board, but especially in 5 to 9 year olds. So it's kind of heartbreaking to see this. And we're going to delve into how to approach these conversations with individuals in a very compassionate manner. Okay. Yes, I've got people saying in the yes, I believe Sonia and Candace. Yes, it's underreported, and because of, I like Nicole said, because of the shame and the stigma. Yes, absolutely, absolutely. Margaret, very underreported. Um, I, Everett, really good insight there. Everett, excellent experience. So um, there, absolutely. I have someone in private chat talking about a lot of times that sometimes people are diagnosed with an overdose, but it may have not just been an accidental overdose. So, exactly. Great feedback there. Great feedback. Thank you guys so much. Excellent. Excellent. So, moving on, we're just going to delve into how to approach the conversations with individuals in a very compassionate manner. So, again, we have a fabulous group here today, and I would like to know how you, as clinicians, kind of establish a non judgmental and supportive atmosphere. Like, what are other ways that you use to convey your support? There are things you can say, like, I'm here for you, I care about you, I want to listen. That sets a really nice tone. It establishes a non judgmental and supportive atmosphere, which is really crucial in clinical settings because it helps create that safe and trusting environments for your patients and clients, and they feel like they won't be judged for their thoughts and feelings, because many times, especially now with social media, people are judged for being open and honest about their feelings. So, and struggles that they're having, especially when it's such a sensitive issue as suicidal thoughts. One is choosing a safe space to talk about that. So, aside from using like a quiet room and a private room, and I'm getting really good feedback here. Correctional, I'm glad that you said that, correctional underreporting. I think that's a really, really important topic too. So, um, yes, Nora just shared, and I've heard similar statements. What Nora just shared in the chat, I could just wrap my car around a tree and no one would know it was not an accident. You're absolutely, absolutely. Katia, you asked about the copy of the slides. We are absolutely going to get you the copy of the slides. I have a lot of goodies for you today. So a lot of goodies that I'm going to be sharing with you because I want you to walk away with a lot of information here. So absolutely. Um, Telehealth, when talking about safe spaces, telehealth, I'd like to get people's thoughts on telehealth. I like telehealth. I feel like that it kind of improves access to healthcare for people that are in underserved or remote areas. Also, if people have mobility issues, transportation issues, I think it's convenient for patients. But some folks like to do therapy or to see patients in their clinic, and that is understandable. It's kind of whatever you like, though. But one of the things I think is really important when you approach the conversation, not just setting the tone, not just making sure it's a safe space, but also using open-ended questions. I love those. I love open-ended questions because it helps all of us get a deeper understanding of the individual's conditions and needs. Right. And so, like, how have you been feeling lately? Or what's been on your mind? Or tell me more about what's causing you some distress. What are some emotions that you've been experiencing? Certain questions that are thought provoking, like what would you like things to be different in your life? So I'll tell you about a colleague of mine, and this was in a behavioral health emergency department. My colleague was really having difficulty getting the patient to open up in a very empathetic tone. Okay, in a very, because tone is everything when you're asking questions, right? But in a very empathetic tone, said, "Tell me about the last time you were happy." And that question really resonated with me. And I'm not advocating that question because everyone has their own style and it really depends on the situation. And of course, your tone has to be appropriate. But it was an eye opening question. And it even caused me to reflect on my life. I just thought, wow, that was very powerful question. And it was an open ended question. So, and also validating individuals' feelings, like making sure that they feel validated as a person. And that can really go such a long way in a therapeutic relationship. So, like, it sounds like you're going through a tough time, that really conveys empathy and compassion. So, absolutely. So, we're going to go over questions to ask individuals. So, Randall said, I work with people who are deaf, and telehealth is essential. Absolutely. Telehealth is great. Great. Oh, Tina, I love that question. What or who has helped you get through hard times in the past? Absolutely love that. Absolutely love that. Emily, I love asking that question. Gives so much information about the patient. Absolutely. Exactly. So fantastic. Great questions there. Thank you guys so much for sharing. I love that. Again, there are a lot of people in the room. There are a lot of people in the room, and you have such good experience. And this is great for all of us to come together. So Vanita said, I like to remind them that they don't have to carry with weight by themselves. I'm here to carry some of this with you. Oh, that is so compassionate. I love that. Love it. Love it. Now, here are some other questions I've put up as well. The great questions in the chat, though. But sometimes when you talk about being compassionate and expressing that genuine concern, that first question, like sometimes people feel that life is not worth living. Would you mind telling me how you feel about your own life? It's really okay to have complex emotions, and acknowledging that to them helps them to openly express that. Or how do you feel about your future? You're showing that you're interested in that person's long term well being. And it allows them to talk about, maybe they want to talk about their hopes and dreams. Maybe they want to talk about concerns or problems that they may feel like they're going to face. And then, is there ever a time that you've thought about harming or taking your life? That's a really direct question. It's a really direct question, but it shows a willingness for you to address that topic and offer the help if it's needed. The last two questions I think are also really good. They genuinely explore the person's um, one, two, three, four down. Really genuinely explores the person's desire for relief. Like a lot of people, they don't really want to kill themselves, but they do want relief for what they're going through, and showing them that that's a safe space to discuss those types of feelings. And do you think about your own death and dying? So this really talks about the contemplation of mortality for people and opening up of any distressing thoughts that they have. But overall, these questions demonstrate compassion because they recognize that the person is having struggles, and then you're offering support and understanding without imposing that judgment or stigma. So, Emily, I like that. I also end my new appointment asking the patient if they could have three wishes for anything in the world, what would it be? I love that. It's thought provoking for all of us, isn't it? So, exactly. Margaret, wonderful feedback. Thank you. Thank you. Thank you. Tina, what or who again, I love Tina's question. I'll be really honest about that. It's phenomenal. Phenomenal. All right. Love that. Okay. All right. Now, these are all excellent questions. Now we're going to move to the questions that we should not ask. Okay. These are questions that we should not be asking. And I'm sure that most of you are not, but this is just kind of a good reminder here. These questions you see on the screen should absolutely be avoided when you're talking to someone who is suicidal or contemplating suicide, because they could be potentially harmful. They could be could be construed as insensitive and probably a little bit counterproductive. So, and let's talk about the first one. You're not thinking of hurting yourself, are you? This is a question that's actually really commonly used, but it's problematic because it's a closed-ended question and it implies an assumption that they're considering self-harm. So, and some people may feel like it can come across accusatory. So, might make a person a little defensive. And so, and you don't ever want to ruin opportunities with questions, right? Have you thought about the impact that suicide would have on your family and friends? That a lot of you, that may be a well-intended question, right? But it's guilt-inducing and it increases the person's emotional distress if you ask them that. So, and it inadvertently might make them feel like more of a burden to their loved ones. So, um, number three, don't you think suicide is selfish? Now, I've heard people say this before, not in mental health professional settings, but I've heard people say this, and really it's judgmental, it's stigmatizing, and it oversimplifies a very, very complex issue. Okay. So, and have you tried thinking positively? That is my least favorite. So, because it's really dismissive of individuals' struggles and it implies that their feelings can be resolved just by like changing your mindset. And and that's not the case in dealing with someone with suicidal thoughts. And really, one of my pet peeves, and I don't know if you guys agree with this or not. I love your thoughts. One of my pet peeves is getting on social media and getting on the TikTok. There's YouTube Shorts. There's Facebooks, and these individuals who they tag themselves as influencers and they talk about these types of things and they have no background in mental health at all. So no background in mental health at all. And so, and they're giving advice to people who are listening, right? Because a lot of times now, and there was an article that came out, it's not a study, so I don't want to quote it exactly, but Google, everybody went and searched on Google, but now you're seeing trends of people searching on TikTok when they have a question, or searching on YouTube Shorts. So, and that is, yeah, it's very. Catherine said, I try to find out whether the client is wanting wanting the pain and frustration to end so they can live their lives. That's a really good way to approach it. And I think we just answered the question, the one before that. So very good. So exactly, exactly. Very good. So very good feedback. Very, very good feedback. Now, one part of asking questions is also active listening. And so active listening has much deeper implications than just influencing the social reaction of the individual you're dealing with. So when you're actively listening, you want to be present in the conversation. You want to listen without judgment and reflect and summarize. So there are many things that people like to hear. They like to hear the sound of their name in a positive manner. And they also, if you summarize what the person says and repeat it back to them, the clients and your patients really feel like you understand them. And I love this graphic from a study because in 2015, they did a study, scientists did a study on with MRIs. It's called a functional MRI on participants that viewed assessments of their own personal experiences made by evaluators. And they did it in two different groups, one that were listening and one that were not using active listening. So the group using active listening, groups not using active listening. And the subjects rated evaluators who showed active listening much more positively, but it wasn't just the rating, right? We knew they would get, you kind of assumed, right? They'll obviously rate them higher, but they also rated episodes more positively when they were evaluated by individuals showing active listening, knew that as well, right? Figured that out. That would definitely happen. But this neural activation in the ventral areas was enhanced by perceived active listening, suggesting that this was processed as more rewarding, and it also activated, if you can see on the MRI scans, the right anterior areas of the brain, representing the positive emotional reappraisal process. So you can physically see the brain react to active listening, and that's how important that is. So very good. Isn't that great? Is it? Yep. I got somebody in private chat. Yes, absolutely. I can give you the a copy of the study. It is from 2015. I don't like to go back real far with studies, but yes, I absolutely can share that. So, all right. I love the conversation in the chat. Love it. Love it. Love it. So now one thing I want to talk about is the standard of care in suicide assessments. And so this is obviously when the person first comes to you, you're doing very comprehensive evaluation of their maybe suicidal tendencies. And so a thoroughly assessing suicidal ideation, that really means that you've got to get down in the depth of the patient's thoughts and explore the nature and intensity of their suicidal ideation. That means the frequency and the severity of those thoughts. So you also want to examine their intent and their plans. So it's imperative to investigate those. Now, on the very first slide I showed you, it had 900,000 people had attempted suicide, and they had a plan, but there were 200,000, over 200,000 people that attempted suicide that did not have a plan. It was just spontaneous. And so a plan is important, but it is not always a predictive indicator. So, um, you also want to review a psychiatric and medical history and kind of summarizing that and really scrutinizing that. Like, what have been their past experiences with mental health? Have they had hospitalizations before? Have they had outpatient treatment? Have they had multiple therapies that have not been effective? And medical history as well. Individuals that are dealing with advanced medical issues are also at a high risk, especially those individuals in pain. So, or that have experienced trauma of some kind. So, those are factors that you need to look for, and identifying risk and protective factors. And we're going to talk about that in a little bit more detail. And then determining the level of risk for that is critical. So, because you've got to gauge whether the patient is an intimate risk of self harm or this threat is more long term. So, because that really determines the urgency of the interventions that you need to make. And then developing an appropriate treatment plan, right? And this plan should really address the concerns with a focus on stabilization. And overall, you're going to be evaluating all aspects of that patient's life to gain comprehensive understanding and making informed treatment decisions. So about that patient's care. So, and let me show you what that kind of looks like on another slide here. This is really on the history. This is predisposing factors. You have modifiable factors, future factors that could even be anticipated factors, right? Criminal proceedings is one, change in circumstances, strengths and protective factors there. So all of these really factor in to what's going on with the patient and their history. So Daniel said, I where my questions around, do you want the pain and suffering to stop? Yes, that's a great way. Exactly, exactly. That's great, Daniel. Excellent, excellent. Love this, love it. All right. Moving on, I want to talk about current stressors for individuals because it's really essential that we understand distressing life events. So, and that can encompass various aspects of life. It could be relationship breakdowns, like maybe they have a significant relationship and that it's ending. And that could be a friend, that could be an intimate partner, that could be a breakdown in family relationships. So definite issues there. You can have financial difficulties. Financial instability and economic hardships can really exacerbate stress levels, and that can potentially lead to suicidal thoughts and behaviors. There are large companies where individuals, like I'm going to use Twitter as an example, there are a lot of individuals who had very good wages, felt like they were in secure, had kind of built up a company and kind of built it from the ground up, and then were 70% of them lost their jobs and definitely probably had financial difficulties. And then if you think about that, relationship breakups, because friends at work are still friends, right? And a lot of times after they leave work, those dynamics don't always stay the same. So there could be definitely current stressors going on. And then obviously the last one, loss of a loved one, grief can be absolutely overwhelming. DSM-5 update approach that, I think, in a very compassionate manner. And unfortunately, grief can increase vulnerability to suicidal ideation. So um, other things, just being aware of clients' current stressors is lack of social support. Really, the isolation. COVID kind of did a number on everyone. There was a lot of grief around COVID. There, people lost loved ones, but there was also a lot of isolation, and so there are poor coping skills and feelings of hopelessness and despair. These can all contribute significantly to suicidal thoughts or actions, all of these. So knowing what the current stressors are very, very important. Yeah. And Tina, you listed something really important. The current stressors you've listed are daily reality for 95% of the clients. Absolutely. Absolutely. Yes, and Catherine said severe medical conditions absolutely can lead to SI. So absolutely, absolutely. So when I worked several years for hospice, and there was hospice is a wonderful organization. They are so compassionate when it comes to death and dying, and really focusing on the quality of life versus quantity. But there is also a little bit of a dark side in hospice, because and when we talk, we can move back to underreporting, but people are very sick, and sometimes their individuals would go ahead and take their own lives while under hospice care. All right. And so I'm glad you brought that up, Catherine. That's a really, really important point. So, and addiction, Jane, absolutely. Addiction, that is a huge one. So, absolutely. Very good. Uh, Now I'm gonna move on to the next slide is, and this is going to come in a packet. We've got a packet for you, and it's going to include a few things in that packet. This being one of them is a suicidal ideation checklist. Right, this is a checklist. We've created a checklist for you, and I'm curious to know, based on your experience of this list, and there's a lot on here, but which ones do you consider the most crucial when identifying suicidal ideation individuals? So please, I'm going to give a moment and let you answer. What do you think? And you can have a couple. You don't have to just pick one. You can have a couple. What do you consider the most crucial? And Catherine, you brought up a good point. Exactly. Being a hospice social worker for 12 years, it's sometimes difficult to decipher what's just an expression of frustration or serious desire to end life. Absolutely. And unfortunately, during my time with hospice, we didn't know that until afterwards. And that's really, really difficult. And but we so thankful for individuals like you. But 12 years, that is a wonderful thing. So thank you. Right. We have burden to others, absolutely. Sense of loss, these are coming from the chat. Hopelessness and burdensomeness. Giving away possessions and withdrawal from family and friends. It's a really good one, Elizabeth. A lot of times when people will come up and say, now this was my grandmother's, I'd like you to have it. That's just like a big red flashing light going off, right? For everyone in the room. You're like, wait, what? So absolutely, Scott, hopelessness is highly correlated. Hopelessness is exactly giving away possessions. I got a lot of giving away possessions. Life is not worth living. Profound sense of unworthiness, co-occurring disorders, actively seeking means, hopelessness. Yes, a lot of hopelessness. Engaging in damaging behavior, reckless behavior, absolutely, and just not being concerned with the consequences at all. Right, feeling trapped. Carrie, I'm glad you brought that up. Absolutely. Bullied. I'm glad. Yes, being bullied. That, and we see that a lot now. Withdrawal. Feeling life lacks purpose. Withdrawal. Believe life is not worth eating. Changes in eating habits. Frequent attacks. Unusual calmness. Yes, or sudden happiness following a period of depression. Yeah, that one's a kind of a telltale too. Drastic change in mood. Feeling burden to others. Very good. Avoidance of social interaction. Hopelessness, sense of unworthiness. What I absolutely love about this is everyone kind of has different ones that they feel are triggers, right? And so that's great. In this packet that we're providing you, you have this checklist in there, and then under each area we talk about it more in depth. So there's at least a paragraph. I generally, when I'm writing things, I like to put in studies. I love evidence-based data, peer reviewed, and so I like to put that in there as well. So, absolutely. So great, great. Thank you so much for sharing that. Now, I one of the things I'd like to share with you, and we also we I believe we have this assessment in the packet. If not, we will throw it up. But it's really important that we use evidence-based assessments. And the Columbia Suicide Severity Rating Scale is a remarkable assessment tool for several very compelling reasons. One, it's accessible and it's easy to use. And it does not require formal mental health training to administer, meaning like police officers, firefighters, first responders, even laypersons can use this screening tool. It is notably efficient. It has two primary questions. Now, there are several versions of the CSSRS. And so the recent version is one that is highly used. There are longer versions with like the safety version, and that is a lot longer. But this version is very, very short and you can do it quickly. All right. It's endorsed also by like the FDA, the World Health Organization, SAMHSA, the CDC, NIH. The Department of Defense even endorses this and has for a long-standing period of time for over 10 years. So, and the validity across the the board on this assessment is it's been demonstrated to accurately not only identify suicidal thoughts but actually predict suicide attempts. So, and it assesses that across a really diverse amount of populations like adolescents, adults, individuals, and veterans. So it's really, really an excellent. And when you start to compare it with other scales, like the scale for suicidal ideation, the CSSR just continues to demonstrate its validity and reliability, and it performs really consistently well when it's used in languages other than English. So, which indicates further it's cross cultural. Um, it and when I say other languages, this is available in 114 different languages. So, and there have been studies in many, many, many countries. So, and you could use it in a variety of the settings. They use it in psychiatric emergency departments. They use it in medical emergency departments and outpatient settings and inpatient psychiatric settings. So it's really adaptable and has a really broad application. So I am a huge advocate for this. How many of you use this in the in practice? How many of you use the CSSRS? If you don't, that's okay. Oh, couple slides over here. So we use it, Jennifer, you use it. Yeah, it's a great tool. It's a great tool. I absolutely love it. And we're going to talk a little bit about later on why it's really, really important to do this. We've got a lot of people already using it. So fantastic. Kudos to you guys. So excellent, excellent. Um, and I get excited when I start to talk about it. I know you probably hear that in my voice, but I think it's such a good tool. The prediction accuracy of individuals in a study that who would commit suicide was it was very scary. It was unfortunate, but the prediction was almost right on point. So all right. Now, I'm gonna go over and talk about assessing level of risk because I think it's really important, and it's another reason why I like that Columbia Suicide Severity Scale because it will assess the level of risk for you. So it's low risk, medium, high risk. So it basically tells you what risk level they are. So it's a really good tool. Now, because of time, I'm not going to spend a whole lot of time on this. You will get the slides though, but assessing their level of risk is very, very important. Now, this is also just another slide. I wanted to talk really quickly about the distinction between suicidal thoughts and non-suicidal self-directed violence. Okay, and so, and most of you in here are all professionals, so you know that there are two distinct differences that are really one is about causing harm to oneself, and one is deliberate acts of self-injury without the explicit intent to die. Okay. And so, and I think that when you talk about suicidal self-harm, it's deliberate self-harm. I want to hurt myself. I want to escape emotional pain, maybe physical pain in these circumstances I'm in. Non-suicidal self-harm, we just have to touch on that, is used as a coping mechanism to manage the overwhelming stress, distress, and emotional thoughts. And while the behaviors themselves aren't always intended to cause death, they can lead to physical harm and pose significant risk. You could get staph infections from doing from self-harming. People sometimes will cut too deep. They're really this is not a good thing. And we need to talk about the individuals this affects. So there was a study that showed that in 7 to 16-year-olds, over 53%, and this was a large space study. This wasn't like 50 kids at a high school. This was well over 600 participants, and 53% of those 7 to 16-year-olds had engaged in self-harm, and girls actually reported at a much higher rate than boys, and they were actually much more likely girls were to cut and carve, whereas boys reported like hitting themselves or hitting objects. But the highest demographic was ninth grade girls. Again, they were 3 times higher in rate than boys in the same grade. So, but when we're talking about compassion, we're talking about self-harm. I wanted to bring that in. So, and definitely talk about that. So, all right. Um, Next, I want to go over some protective questions, and I would love for you to share questions that you ask as a clinician that are protective in nature to kind of find out some coping strategies for individuals' well-being. So I think that that's important. So I'd love to, because you did such a great job. Everyone had such great questions. Um, and so I'd love to hear about some of the protective questions that you ask. And some of these are there, like what aspects of your life would you um, contribute to your will to live, all right? And that always conveys a really genuine interest in understanding their sources. Also, if you were to experience thoughts of self-harm, what strategies or actions would you employ? That really encourages individuals to reflect on coping mechanisms. And then tell me what you would need to feel more optimistic or hopeful. That really expresses an understanding of the person's desire for optimism and hope, and really invites them to share, what are your needs, what are your preferences, what can I help you with? So, and so overall, these questions are really compassionate and empathetic because they prioritize the individual's well-being, and they open and foster open communication. And here are some other protective factors, and I want to look back at the chat. um, Denise says, for gun owners, where's your gun? And do you think you should have it in your possession? I'm going to touch on that in just a minute. So, yes, I'm glad that you brought that up. Uh, Tina, what or who brings meaning to your life? Tell me more about him or her. I love that. That's fantastic. That's fantastic. Claudia, I'm curious about who keeps you from going through with a plan or thought. That is a wonderful question as well. That absolutely wonderful. With kids, I ask what they look forward to on the weekend after school, and I ask about the meaning of their pets. Pets are a huge protective fact. I could not agree with you more. I absolutely love that. I have a family. I love them greatly. I was fortunate enough to get an instant family many years ago. As some of you know what that means, just an instant family. So I have children, and they are absolutely my reason for living. But even though one of them currently has COVID, and I'm sure they're going to share the wealth with me. But before being gifted with children, I had and still have a beloved dog. And despite having a close relationship with family members, my dog would be my number one reason for living back before my family, and she's still probably the favorite. So, so that's absolutely true. Pets are huge protective factors for kids, for teens, and for adults. Absolutely. Absolutely. So, but figuring out who that is in the person's life is fantastic. Julie says, I ask all my clients about pets during intake when I'm asking about living environment because they're so important to those of us who have them. They are. They absolutely are. 100%. 100%. I love this question. I'm curious about what or who keeps bringing meaning to your life. I love these. These are all excellent, wonderful, wonderful questions. All right. I absolutely fantastic. Thank you guys so much for sharing this. What or who brings joy on a consistent basis? What or who brings light and laughter to your day? Wonderful. Love this. I love this. If it's okay with you, I would like to take some of these questions that you ask, the protective factors and the genuine, compassionate questions, and write them down. I would love to be able to do that and share that with everybody because I think these are fantastic. And have you have provided this, and all of these are absolutely wonderful. And there are new clinicians out there that are struggling, that don't know where to turn, and this is absolutely wonderful. Yes, I'm completely willing and able to give a copy of these chat questions if everybody that has put one of those in there agrees. If you say yes in the chat, we will get that out to you. Absolutely. So, because I think these are fantastic. So, all right. Now, really quickly, I'm going to have to breeze past this, but I want to talk about safety plans. This is also in the toolkit that we have provided, because when you talk about a safety plan with your clients, it's going to open up new conversations. And these safety plans have to be created outside of a crisis. Trying to create one at a time of crisis is really futile. It's not going to work. So, safety plans provide, of course, enhanced safety. They provide empowerment to the individual, to your client or patient, because it gives strategies that they actively participated in. And so that also empowers them to take an active role into managing that when a crisis situation develops. And so they can identify triggers and warning signs that, like, these are specific things that happen before a crisis. And there's this kind of awareness allows for early intervention, also having resource utilization, like, and we put numbers on this here. These are the crisis plans. 988, love that if you're in the United States, but there's also a whole list of other crisis hotlines for people that are in domestic violent situations, that have been sexually assaulted, and the Trevor Project, all of these really wonderful resources for people to contact, because you are not always available 24 hours a day, 7 days a week, right? And so we need to provide them resources they can do on their own, and also other resources. So, and customization about these safety plans is fantastic because it's tailored to each individual's unique circumstances, needs. For some people, like for me, I like to take a walk. That helps me calm down. But for someone else, like playing a video game and connecting with friends online may actually help them in a crisis. There's a study out now that says that individuals, you talk about people that you really know in person versus people that are your online friends, people have 55 physical friends on average, acquaintance type friends, but they'll have 121 online friends compared to that 55 physical friends. And when you ask another study was recently done about close friendships, and 50% of Americans say they have a close friend that's entirely online, meaning that this person, they met them online, they communicate with them on there, and they have never met that person in face to face. So this is a really good thing. Um, so that is one of the things. These crisis plans are fantastic. Safety plans and crisis plans are. There's also, you know, safety interventions, and we're going to go back to, we're going to talk about the gun thing now. Okay. Safety interventions at home are absolutely imperative to suicide prevention, and irrespective of immediate risk. And among these interventions, safe storage of a firearms is paramount in that role. So even in instances where suicide risk may not be overtly evident, so that could be employing practices like utilizing a cable or trigger locks, or storing firearms in lock cases or a big safe, and maintaining a separate secure storage of the firearm and the ammunition. And that reduces the risk of kind of, I want to say, unauthorized access. All right, maybe that's not the best word, but unauthorized access to that. Because, and if you need assistance on that, there's something called the National Shooting Sports Foundation. They have a website that will talk about this. And what last webinar I did, I had a guy that got in it and he was fussing about like guns. Listen, I grew up in the country. There are guns all around. My opinion about guns is irrelevant. Statistical data shows that 49 to 50% of the people that kill themselves do so with a firearm. So also, you are 2 times more likely to kill yourself with a firearm than you are to be killed with a firearm. That is statistical data. All right, that is statistical data. And when I first heard that, I was like, wow, but that is the truth. You are 2 times more likely to shoot yourself with a firearm than someone is to shoot you. So please be careful with those guns. Another thing I want to talk about is medications. That is like just as critical, because especially when you have clients that have strong sedatives, narcotics, these opioid medications, they need lock boxes. You can get that from the pharmacy. People also in the United States, because they have trouble getting pain medication, will hoard pain medication. And that is not good either, because it may be expired medication, but sometimes it will work just as well, if not a little bit more better when it's expired. So leftover medication needs to go to the local pharmacy and they will get rid of it. Okay. Because during these times of crisis, proactively removing potential harmful objects is key, especially like knives should be removed, ropes, cords, any sharp object really, to cultivate a safer home environment for individuals that are in there. Really quick story, 30 seconds. I had a child that was, their parents did everything to make the house as safe as they possibly could. They removed all cords, all sharp objects, everything. What they forgot to remove, and listen, I wouldn't have thought about this either, was the video game cord, the cord that plugs into the wall that goes to the video game console. They forgot. It's not forget, it's just an oversight. It was overlooking, because you don't normally think of that. You have to have things plugged in, and unfortunately their child attempted strangulation, and was not successful. But see, and we're going to talk a little bit more about that as well. So the other area that I want to come over, and I'm going a little bit quick, this is a slide on the resources, but your documentation. Okay. A large majority in the United States are practicing what's called documentation. So, and if you want to know the statistics, if you have a patient that commits suicide, 25% of the time the family will contact an attorney, even if you have done everything you possibly can. And I think that we need to be really clear as clinicians that you give everything you can to your patients, and you do everything that you possibly can. And you're probably like, well, October, how do you know that? I know that because you're here at this webinar today learning compassionate techniques to engage your patients. You give everything you can. And unfortunately, in our profession, individuals will commit suicide despite your best attempts. And to think that they won't is unrealistic. And it's almost like saying a cardiologist isn't going to lose a patient due to heart disease. You know that's not true. And it is the same in mental health. And some people might say, well, suicide is preventable as well. Well, so is heart disease and diabetes in some cases, but it still happens. And so documentation is the part that's going to protect you as the clinician because you have given the best care and you've done the reasonable standards exactly. And I like how you said it. Documentation is absolutely everything. Love the way you said that. So we have progress notes available, kind of what it should look like on a progress note, especially if the patient is suicidal. They do have access to a firearm. We have that in our packet. And also, I want to talk about developing a treatment plan because not only do you need to document what's happening, you need to document exactly how you are going to treat that patient and what the treatment plan is going to look like. All right, developing a treatment plan. We have in our packet a danger to self treatment plan that you can use. So, absolutely. We have that. So, the progress note that you can use and a treatment plan as well. And I want to talk a little bit about ethical and legal considerations. And we're running low on time here, but I wanted to get out 10, 1 out of 10, 10 being the most important. How important do you think documentation is? Just type it in the chat. How important do you think documentation is? I'm getting quite a few private chats. It's a 10. Absolutely, it's a 10. Absolutely, it is absolutely a 10. So 11, I like that. 100, the 10 plus. Absolutely. Absolutely. So I will tell you with the law firm that I used to work at, regardless of how wonderful the clinician was and how many patients that they treated, whenever a lawsuit came up, we looked at their documentation for that particular client because the truth of the matter is that you're not going to be able to remember. A lot of times we talk to clinicians and it would be from 3 years previous and they didn't, especially in inpatient settings, they would not even remember the patient. And that's okay because you see so many patients, right? The problem is that they absolutely remember you. So, Catherine says if it didn't document it, it didn't happen. You're absolutely right. I'm just going to hopefully you've kind of looked at this slide on ethical and legal considerations. I think that that's really important. As far as that, I think that it's really important for us to kind of look through that and to kind of see all of that. But I also want to show you. I also am going to show you documentation. But here's another area. It's really, really important for you to know your state laws as far as if someone is suicidal, they are high risk. You think, well, what am I going to do now? And that's a problem a lot of clinicians face. Well, if I ask them if they're suicidal and they tell me they are, then I have to do something. You're right. You do have the duty to take action, but you really need to know what your state laws are. Like I currently live in North Carolina, have for a while. In North Carolina, anybody can petition anybody. I can go say my neighbor is suicidal. The police will come, put my neighbor in handcuffs, and take them to the behavioral health center. Not fair, not good. People, and you're probably thinking to yourself, do people lock up their spouses when they get mad at them? Absolutely, that happens here. Absolutely, that does happen. It's unfortunate, but it does occur. So, however, know what your laws are. And I hear a lot of people, and I remember a lot of people getting in trouble because they said, well, I had a good relationship with my patient. They were suicidal. I didn't want to do anything. And then it happened. And despite the good relationship that you have with your patient, you should follow the letter of the law because you're going to continue to have other fantastic relationships with other patients and clients of yours, and you want to be able to continue to have your license to do so. And that's not a scare tactic, that's just the truth. So exactly. So now some other things I'll just go over here. Self-care. And I really want to talk about this. I'm only going to take just a short period of time, but I think it's no. mental health providers. And this is well documented. There's studies that show burnout and professional impairment. And as we're talking about this, I would love for you to share some of the things in the chat that you do for self care, because caring for yourself is really a unique journey, but it's essential to explore kind of what resonates with you and what brings you comfort. And know that there's not one size fits all approach to self care, but it's perfectly okay to experiment, find out what is best. And there isn't a magic solution, right, for all the challenges that you face, but self care can be a very valuable tool, and you deserve it because you're in here, you're trying to learn how to take better care of individuals, you're sharing. And I'm sure the individuals, the ones that are in here today, not only probably do you take care of your patients, but you also probably do the same thing with your loved ones. But you also need to take care of yourself, right? And so often, all of us in this field, we forget to do this, right? We forget to do this. We put ourselves on the very, very back burner. So we've got some wonderful things here. I love to sew, journaling. Journaling's fantastic. Listening to music, dining out, study, spending time with partner and family, supervision, jogging. These are coming in fast, so I'm sorry if I'm messing this up. Maintaining boundaries, love it. Exercising, watching a Hallmark movie. Okay, totally can relate. Decompressing, doing some of your nails, massages, lunch breaks are sacred. Absolutely. A lot of journaling. I love that. Reading a book, being on a boat. Oh, absolutely. Absolutely. Walking. Yes, walking on the beach. Vibration meditations on YouTube. I'm going to have to check that out. There a lot went up, so I hope I was able to get that. But as you can see in the chat, really, really great time. Thrift store shopping. I love that. Crafting, massages, excellent. All really wonderful, wonderful things. So this is great. This is great. This is something, please look at these. I can even share these in a separate sheet because I think they're wonderful, wonderful coping mechanisms of self-care. All right. Now, y'all have been absolutely wonderful. We are going to go for questions now. I want to make sure I get to your questions. I appreciate your participation so much. I do want to show our program very quickly for documentation in the program and what that looks like. And so with documentation, when you're doing progress notes, I can put in here that the client has symptoms of. I can say that they have depression, that depression continues and it's worse. I can talk about the fact maybe they have crying spells, that's definitely present. They have fatigue, that continues. Maybe they're irritable, that continues. Libido is decreased, that's gotten worse. I could say that there is sadness and that symptom's absolutely present. And maybe there's feelings of worthlessness and that symptom continues. And then suicidality, I'm going to say that they have, um, they wish to be dead, and and perhaps but they're denying intentions, but they're also minimizing suicidal ideology, guarded about that, and they say that that's fleeting. And so then I can go in and talk about what we're going to do. And there's my access to firearms. So maybe, yes, they have access to firearms, and I can type out exactly what we're going to do. I can also put in certain things like in our program, you can create buttons. So I could say safety plan, and I can put the patient's name in. So I'll put their name, and this writer reviewed and completed a safety plan during this session. Once I put this in this one chart, the button will then be there, and I'm in Kyle's chart, but if I'm in Nicole's chart or Amy's chart or Sandy's chart, that button will be there and it will put their name in. So I can also talk about their behavior, if maybe their self-care has been reduced and their medication compliance has been irregular and their functioning at work is marginal. So, and maybe their impulses are poorly controlled and they're not getting any sleep. There's sleep problems, falling asleep, staying asleep. And I can talk about verbal content. Maybe they're having problem in a relationship and a problem with work, and they have a lot of depression going on, and they have low self-esteem. And then I can talk about what I'm going to do there. So I'm going to say maybe our session goal was to give them coping skills, and to talk about self-esteem and some of our interventions, or to give them support and vent feelings, and maybe they're counseled about stress reduction techniques. And then I can also put in additional key topics in here as well. And I'm also able to put my own buttons in here. Maybe I don't work with family counseling or counseling, so I can remove that, and I don't work with tobacco cessation or weight counseling, so I can remove those things. But maybe I am going to put in here, maybe I do EMDR. Okay, so, and I'm going to say EMDR will continue weekly or per session. And this is just a quick little thing. I can put that in there. There's my EMDR. When I go back, these have disappeared, and there's my EMDR, and it will go right in there. So really able to customize notes and really drill down. And then I can also justify level of care for our payer sources, right? Unfortunately, reimbursement is a big thing. So I can say that outpatient is still needed because it's interfering with their day-to-day activity and they required continued treatment. And so, and then I just move forward and I can create my note, and I can also link treatment plans into the note. So if you created a treatment plan, you can quickly link it into the note. So the text automatically fills in. This is iCan Notes Plus. Yes, Belinda's like, I use iCan Notes. My screen does not look like this. It works exactly the same as iCan Notes, but it's iCan Notes Plus. So absolutely. So, and I think they put the free trial up there. So, but it gives you a really pretty note. I have a big logo here, but real pretty note, and it takes 1 to 2 minutes to create. I am going to hit the QA because we got some assessments. Who is capable of completing an assessment? Does it have to be a clinician? What about a mentor, coach, teacher, friends? I think they're frontline social workers who are afraid of approaching these conversations for fear of not being in their role. I think really anybody that, when you're dealing with, and this could be down to nurses that are really, in inpatient settings or outpatient settings, can ask who, they can complete assessments, and anybody can ask uh, how people are feeling, right? And the CSSRS can be done by anyone, even lay individuals. But I think that you brought up a good question, Megan. I'd love for other people to chime in too, but there are certain states that require certain disciplines to complete assessments. Um, so that is one thing, or they must bill under certain disciplines. So it's really dependent on the particular states. Where do you find information about your state laws? That's a great question, Melinda. Information about state laws is generally going to be found on the state website. Like North Carolina has a website. Maybe that's something that we need. We are always putting together informational packets like the one we did on behavioral health assessments, open domain assessments, and kind of their reliability and validity. And so maybe that's something that we put together on different states, because it does vary state by state. And then the problem with that is it also changes as well. So some places it's called a baker, some places 5150. North Carolina, it's a petition. It's just a petition. So maybe we can put together some information. I answered the question about that. So what do you recommend on managing children with SI from a legal and ethical perspective? Mary asks. Ooh, I could talk about that all day long. Maybe that's something, maybe our next webinar we need to have on managing children with SI, because that is sometimes a completely different ballgame than adults, right? So, but the CSSRS can be used across adolescents as well. So again, that's a go-to assessment. Sonia said, my safe tone of letting people know what they're feeling, how they're feeling this way. I love that. And a warm bath and wine and jazz. Okay, you know what? Yeah, yes, that sounds fantastic. So, um, Abby, we talked about that earlier. So really good, really good. I cannot thank you enough for your participation in here today. I really, you guys were absolutely wonderful. Absolutely wonderful. We're getting a lot of yeses to a child training. So I do think that needs to be next up on the block. Thankfully, the people that arranged that are in this webinar currently. So they're hearing this is that as well, your requests. So, but I cannot, again, you guys are outstanding in the chat. Thank you so much for being here today. Again, um, y- I am going. Your questions that you came up with are so valuable, and I think most everybody said yes. So I'm going to be sharing those. So, and we will definitely do a child SI training. So thank you guys so much. Thank you for your time. Y'all were absolutely wonderful. Have a great day. Bye bye.